Hi, everyone. Thank you for joining us today as we discuss caring for those with treatment-resistant depression. We'll be providing an overview of treatment-resistant depression, including current treatments, investigational treatments, and then we'll also wrap up with some patient stories and Q&A. There will be some poll questions throughout and Q&A at the end. Please place any questions using the Q&A feature in the presentation portal. Thanks for joining us. I am Kim Cordova. I have been a pharmacist with Genoa Healthcare for 6 years now. I'm currently part of the procurement team and manage clinical procurement and trade relations. Prior to this role, I spent some time in independent pharmacy and retail pharmacy at a big chain, and then was able to join Genoa a few years ago and move to Southern Colorado to be closer to my family and open a new pharmacy location as well. And that's actually where I was able to meet Alicia because we both work together in the same region.
Yes, hi everyone. My name is Alicia Garcia Afa. I'm the manager of pharmacy operations here in Genoa in Aurora, Colorado. A little bit about me, I graduated in 2014 from the University of Colorado School of Pharmacy. After a brief stint in retail pharmacy management, I left to be the chief pharmacist for a long-term care pharmacy before coming to Genoa in 2019 to open a new site on the eastern plains of Colorado, so a few hours away from where Kim was, but we still worked pretty closely together. I transferred to the Aurora site in 2021, and I've been here ever since. I am married to my husband of 5.5 years, and we have 2 children, a 4-year-old son and just about a 2-year-old daughter who keep me on my toes and keep me very busy when I'm not at work. I'm so honored to be here with you all. I was able to work, as we mentioned, closely with Kim here when she was a site manager, so it's a pleasure to be presenting with her to you all today.
Thanks. Those kids keep us busy, especially in summer, right?
I know.
Never a dull moment. So we'll start here with treatment-resistant depression, and that term often refers to patients with major depressive episodes that do not respond satisfactorily to at least 2 trials of optimally dosed antidepressant monotherapy. It's estimated that about 30% of people with major depressive disorder experience treatment-resistant depression, or TRD, in their lifetime. TRD affects about 1.1% of the general US population, so quite a number of people. Here we have a visual I'm sure many of you are familiar with from the STAR-D study. The STAR-D study is essentially the landmark antidepressant therapy study. It was published in 2006. Patients in the study received 1 to 4 steps of antidepressant treatments of 12 to 14-week duration. All patients initially received citalopram, and if they didn't achieve acceptable response in the first step here, they then were able to add another treatment such as bupropion or buspirone or cognitive therapy to citalopram, or it was changed to another agent, whether that was another SSRI, bupropion, venlafaxine, or just therapy. And then again, they were able to have that treatment for 12 to 14 weeks. Depending upon their response, they moved on to the next step. As you can see here, only less than half of patients actually received or experienced an acceptable response to treatment. And so after that first step, then they moved down here to the next step, and still only a small amount of patients actually achieved an acceptable response to treatment. So as those steps proceeded, there's a significantly reduced response to treatment. And that's why it's really necessary for there to be alternative options available and other mechanisms of action. This study was done with the treatments that were available at the time, so SSRIs, SNRIs, so things like sertraline, citalopram, venlafaxine, bupropion, and it's been almost 20 years, I can't believe it, since then, and a lot of new agents have come out and more are being investigated, which we'll discuss today.
Yeah, thank you for that refresher. I haven't seen that since pharmacy school, so I appreciate it.
It's hard to believe it's kind of that old, so to speak, but that's what we're working with, and that's what was available at the time. So it's really exciting that we have some other options and now some time in treatment where we have patients that are experiencing these new options. In addition to the intangible burden of not achieving adequate response or full remission with each treatment step and residual symptoms, there's a significant economic burden as well. Here on this chart, the orange line represents the expected share of economic burden attributable to TRD had the per person incremental costs of TRD and non-TRD major depressive disorder treatment been equal. This chart really illustrates the significantly higher economic burden of those with treatment-resistant depression. As you can see here, even just looking at the healthcare costs, significantly higher for those with treatment-resistant depression. As patients are diagnosed and treated with major depressive disorder, you may consider other currently available therapies. In all cases, whether it's an SSRI, SNRI, transcyclic antidepressant, or MAOI, want to make sure that the patient is given an adequate trial, so an adequate amount of time to try that medication, and at a therapeutic dose. And so oftentimes we might hear somebody on 5 milligrams of citalopram starting low and not titrating up to a therapeutic dose. So it's definitely important to make sure that that's a consideration when treating patients with depression. Another consideration is comorbid conditions. We want to consider physical comorbidities such as hypothyroidism, Cushing's syndrome, Parkinson's, malignancy, anemia, and other dietary deficiencies as well. Also consider psychiatric comorbidities, such as substance misuse or dependency, anxiety disorders, eating disorders, personality disorders, and post-traumatic disorders. Sometimes adjunct therapy is appropriate too. Do you see that in practice, Alicia?
I do. I would say that most of our clients are on some sort of adjunct therapy, whether it's lithium as listed here, or something like Abilify, which is a second generation antipsychotic. Most people that we have are on at least dual coverage for depression. There's also something that's not on the slide, but we use quite a bit of it at our site. It's called L-methylfolate, which is a form of folate or B9. In the body, it regulates serotonin and dopamine naturally. So supplementing someone who's deficient in that can be used to enhance an antidepressant response, as low folate levels have been associated with depression and a poor response to antidepressants. And that actually leads me into talking about the next point of genetic testing. So if someone has a genetic variant of a gene that converts folic acid to L-methylfolate, they'll have a deficiency. So having someone go through genetic testing to determine if they have that variant, then automatically they know, okay, let's supplement with L-methylfolate, and you should see that enhanced response. They're actually using genetic testing in even primary care clinics. I know that when I had my son is 4, and when I had him, I ended up with really severe postpartum depression. And even though I worked in a mental health clinic, it took me forever to finally say, hey, help me. But when I finally did, the first thing that they mentioned was genetic testing, which I was kind of like, what? Why would I need genetic testing? I already have postpartum depression. But they told me, oh, hey, this is going to find the better option for you faster. So you go through genetic testing to find out what SSRI or what SNRI might work best for you right away. So you cut down the need for trials to find out the best option for you. So it's really great that even primary care clinics are doing this to help someone that needs that urgent relief. It just cuts down on the trials that are needed. And then of course you have psychotherapy or talk therapy, which is still a mainstay of mental health treatment.
Yeah, it's nice to be able have opportunities to cut down on that time, because if one trial is 12 weeks, that time starts to add up, and that
it's
people
a
don't
long
have that time.
Yeah, definitely.
And here we have our first poll question. For those of you in the audience here, the question is, do you treat treatment-resistant depression in your clinic? Please select yes, no, not currently, but want to start offering it. We'll give everybody about 30 seconds or so to answer there. And I don't know what you experienced, Alicia, while everybody's answering, is with the genetic testing at the clinic I worked at, they had it was an oral swab. And so they'd swab and then they'd send it out via FedEx. And I think they'd have results within like less than a week.
Yeah, that's exactly what my primary care clinic did. It was very easy. Like, I think those, like the ancestry, DNA, and all of those things, they use the similar technology. So it's way faster than you think.
Yeah, so not remotely as invasive as you think. So here are our results. Yes, 66%, no, 26%, and 8% not currently, but want to start. I am a little bit surprised the no. I would expect to see that higher because it's so prevalent. But hopefully, if you're not currently treating treatment-resistant depression, you're certainly considering it, as our sites can certainly help support as you start that treatment at your clinics. Let's discuss some currently approved treatment-resistant depression options. First, we have Spravato. Its mechanism of action differs from conventional depression medications, and though it's not completely understood, it's thought to be through NMDA receptor antagonism, which affects GABA and glutamate. Spravato is, as you can see here, S-ketamine, so I'm sure you may have heard of ketamine, and Spravato is commercially available as a nasal spray and a little bit different. It's the isomer of ketamine, so probably it's supposed to be the more effective formulation of it. It's indicated for treatment of treatment-resistant depression in adults and depressive symptoms in adults with major depressive disorder with acute suicidal ideation or behavior. Patients often experience a quick onset of action, with results seen within days or weeks. So much different than that 12 to 14 weeks that we talked about earlier. Like I said, it's a nasal spray dosed twice weekly, usually for 4 weeks, then adjusted to once or every 2 weeks, depending on patient response. And the package insert and their website has a lot of detailed information as well, with some good visuals of how to determine the treatment frequency. It also has a somewhat favorable side effect profile in that the side effects associated with Spravato aren't your typical antidepressant side effects, such as weight gain or sexual dysfunction. Most of the effects seen with Spravato are associated with the actual administration of it, so such as increased blood pressure, dissociation, or sedation. Due to these risks, Spravato can only be administered under direct observation of a healthcare provider. There are some barriers such as cost, and there are lots of programs available to assist with cost as well, that our pharmacies can help support that. Prior authorization can be a barrier. Generally, prior authorization includes proof of those 2 failed trials, which generally a lot of people, unfortunately, have a history of it. It's just a matter of having the documentation of when those trials occurred for the insurances. Another barrier is treatment time. As I said, it can only be administered under supervision by a healthcare provider. And due to those effects, patient also can't drive home after therapy. So there is some time. It's a 2-hour monitoring, so it's a lot of time in the clinic there. But sometimes that risk the benefit of the treatment generally outweighs that risk. And then those treatment side effects. But again, patients are monitored and supervised to help to manage any side effects that might occur. Alicia, are these things that you experience at your clinic?
Yeah, you know, we definitely, I would say, see all of these barriers on a daily basis, but we've become pretty good at managing them and overcoming them. So we work very closely with the facilities that we fill Spravato for. We fill for a few different clinics that do quite a bit of Spravato. And we communicate daily via email or phone. Usually email works the best, where either it's us saying, hey, this one's needing a prior authorization. Let me know when you have it, what else you need from me. They'll email back literally within an hour or 2 and say, okay, it's covered. here's, the auth number. So it's a pretty quick process as long as they have those diagnoses of that severe depression, I think is what's required for most plans. And so we provide support wherever possible. We also, with Genoa, we have what's called a consumer medication coordinator, or a CMC for short. So it's a representative of Genoa that's in certain clinics where there is not a Genoa pharmacy yet, that helps coordinate care. So they'll help get, whether it's deliveries to the clinic or help with paperwork needed for prior authorizations, whatever we can do to work together to get the treatment accomplished for the patient is what we do.
That's great. Support all patients, and then certainly with the Spravato as well, we're familiar with that.
Yeah.
Spravato, it's only available through a restricted program known as the Spravato REMS. It's a program that's required by the FDA to ensure safe use of Spravato. Since it can only be administered under direct supervision of a healthcare provider, so it's offered right inside of the clinic, patients are monitored periodically for at least 2 hours. Monitoring consists of blood pressure checks and monitoring for symptoms of sedation and dissociation.
Yeah, and as you mentioned, Kim, with the REMS program, pharmacies have to be certified in order to dispense Spravato. So my pharmacy is certified, and in fact, all Genoa pharmacies are certified as well. So if anyone's interested, you can reach out to your Genoa partner or the manufacturer, Janssen, and we can help you get in touch with them if needed to help take the steps needed to become a Spravato treatment center.
Yeah, and it really doesn't have to be anything significant. There's a space, and yes, the patient's monitored, but you don't necessarily have to be sitting with them the full 2 hours, just periodically checking in. And so there's definitely ways it can be implemented into the workflow of a typical clinic. Which brings us to our next poll question here. What barriers are preventing you from offering Spravato treatment in your clinic? Cost, staffing shortages, REMS certifications, or transportation issues, or other. If you'd write in the chat there, if you select other, we'd appreciate it.
Did you do Spravato at your clinic, Kim?
No. They were looking at it, but then COVID kind of made
yes.
made that a bit of a challenge. And now here we are years later, I don't know if we're years beyond it, but at least figuring out a way forward. And so that is something I was actually just talking to the staff there yesterday. So looking at exploring that possibility and incorporating that, like I said, right into their workflow and having a space for a patient to be. Great. So it looks like here we have 28% said cost was a barrier as their barrier, staffing shortages, which we certainly understand, and COVID played a role in there as well with staffing. REMS certification, not as big, but again, there's those opportunities that us or the manufacturer can support. Transportation and others. So, Alicia, can you see what the others were?
I can't. It says,
okay,
you did not answer this question. Is what it says on mine.
We'll take a look at those at the end. But don't worry, we have the information somewhere. So if there is other that we can address and help you with, we'll be in touch. The next treatment that we have for treatment-resistant depression that's available is Symbiax. It is a fixed-dose combination of olanzapine, so Zyprexa, and fluoxetine, Prozac. It is indicated for treatment-resistant depression, also for acute bipolar major depression. And as I said, it's a fixed dose, so the two of them in combination together, so one dose rather than taking them separately. It's dosed once daily and indicated in patients that are 10 years of age and older.
So with the barriers to this medication, we actually do see this medication here and there, seeing some orders come through. The biggest barrier to this is cost and a prior authorization. So, and even if it does go through, it ends up being still a high copay on the commercial plans or the Medicare plans from what I've seen. So a lot of times a way to go around the barrier of cost is we'll make the recommendation to split it up into its separate generic components. So 2 prescriptions instead of 1, which usually I'm a real advocate for lessening the pill burden, but in this case, this has just worked much better to have separate olanzapine and separate fluoxetine doses. And then, as you mentioned, Symbyax comes in that fixed dose combination. So if they want to titrate, it's a little difficult. So with the 2 separate agents, we've seen it a little easier to be titrated one or the other. And we have several people on that are doing very well.
Yeah, it's nice to have the combination if you like it, that lower pill burden, but then also have the flexibility to recreate it.
Absolutely.
Maybe less expensive as well, and then have that flexibility. That's probably the biggest piece, is that flexibility in dosing.
I agree for sure.
Another FDA-approved treatment for treatment-resistant depression is electroconvulsive therapy, or ECT. It's a non-invasive procedure done under general anesthesia in which small electric currents are passed through the brain, intentionally triggering a brief seizure. ECT seems to cause changes in brain chemistry that can quickly reverse symptoms of certain mental health conditions. And though there are many misconceptions with ECT treatment, I'm sure we've all seen the movies, it's quite effective. And a treatment course is typically 2 to 3 treatments per week for 6 to 12 treatments. Generally, patients undergo ECT along with taking an antidepressant or psychotherapy. Patients may experience treatment side effects such as headaches, upset stomach, memory loss, confusion. Side effects are generally short-lived and improve over time. In addition to the misconceptions and stigma that surround ECT therapy, another common barrier is availability. Trained practitioners are needed, anesthesia, generally a team there, and space, and also just a lack of physical treatment space, because you need, a secure space and then all of the supplies needed to have someone under anesthesia. So significant barriers there. In addition, there are some other options such as repetitive transcranial magnetic stimulation, or rTMS therapy, and deep brain stimulation. In fact, there's a new modified form of transcranial magnetic stimulation that was approved late last year, should be available soon. It compresses several weeks of conventional therapy into just 5 days. Do you guys offer ECT at your partner clinic?
We don't at this time, but I do know that clinics in the Denver area do offer it. A friend of mine actually a few years ago approached me about this, asking if I'd heard of it. And she had been on antidepressants since probably more than half her life. She was in her 30s since she was a teenager, pretty much. And she wanted to get off the medication because she wanted to try and have a baby and didn't want to worry about any contraindications with that. And so I was very skeptical when she asked me about this, because like you said, you've seen the movies and it looks a little interesting. So I was like, well, I'm not, good luck. Let me know how it goes. And she actually did amazing. And she's off the medications now. They just had a baby a few months ago. So I guess it can work. It's proven. So it's awesome.
How cool, like that she, one, had the confidence to take that leap and try something that was a little bit unconventional, and then now to have a baby.
Yeah,
So,
absolutely. It's like the story that you want to hear from these things.
Mm-hmm. That's true. Here we have another poll question. Does your clinic currently offer ECT or the repetitive transcranial magnetic stimulation to patients? Yes, no, not currently, but interested in learning more, or it's not allowed in my state. And give everyone a few minutes to answer. Well, maybe not a few minutes, a few seconds. Not surprising here, the majority of responses are no. As we said, there are a number of barriers, but hopefully in time those barriers will be overcome, and more stories like what your friend experienced, Alicia, maybe that will allow for it to be more widely available. So thank you everybody for participating. Let's switch gears a little bit and review some emerging treatment options for treatment-resistant depression. There are a lot of things being investigated, and we have 5 options that we'll discuss today. First, we have Auvelity. Excuse me. This product is actually FDA approved, but for major depressive disorder. It's a combination of dextromethorphan and bupropion.
I have to say, Kim, when I first saw this product, when it first came out, I knew nothing about it. And my first question was, why is dextromethorphan a cough medication mixed with bupropion?
You don't usually hear of cough medicine being used for depression.
Right.
And it's interesting in this product, the dextromethorphan is actually like the active ingredient. Bupropion, we've heard used for treatment of depression, but in this instance, bupropion is being used to enhance the concentrations of dextromethorphan by inhibiting the CYP2D6 process. So then that increases the dextromethorphan concentrations. And it's thought that it relates to glutamate and monoamine signaling. So and then also NMDA. So somewhat similar to like what we heard with the Spravato or S-ketamine, but another different mechanism of action of those, what we've heard of, previously, like serotonin and things like that. So a little bit different. And this one, the components are available independently. Cough syrup, dextromethorphan and bupropion is available independently, and like the Symbyax, but you can't quite recreate that. The time release formulation, the dosing are not the same over the counter. And so you can't really make those independently and be the same, achieve the same goal of what the product is available. There are some copay assistance programs. We do see dispensing of this across our pharmacies. I wouldn't say that it's significant, but we do see it dispensed around the country. And so it is another great option. And then it is oral. And so that's something to keep in mind. Sometimes the S-ketamine or ketamine clinics that are injected, sometimes that's a barrier for patients. And so it is nice to have another option that's a different mechanism of action and oral. Another investigational product is Sage 217 by Biogen and Sage Pharmaceuticals. It's an oral formulation of zuranolone. The mechanism of action is different than currently available antidepressants. It works through positive allosteric modulation of the GABA A receptors. The active ingredient is actually currently available as Zulresso. It's a 60-hour infusion indicated for postpartum depression. So this will be an oral formulation of that product. And it's interesting, it'll be dosed episodically. So once a day for 14 days. And so that's different than what we are seeing currently, where somebody has to take something once or twice a day for 12 to 14 weeks. It's currently under investigation, and they submitted for FDA approval, and their PDUFA date's in August. And so expecting that to be on the market, if approved, late this year or early next year. So really exciting to have another option. Yeah, and something a little bit easier to take something once a day for 14 days versus a 60-hour infusion.
Exactly.
But even a 60-hour infusion it's that postpartum depression is a gap in therapy. And so that's been a really great option to have for patients too. Next, we have SPN 820 by Supernus. It's currently being studied for treatment-resistant depression. This one has another novel mechanism of action. It's a selective brain mTORC1 activator affecting the rapamycin complex, which plays a role in central signaling and regulation. The changes caused by SPN 820 are consistent with positive effects on mood, cognition, and arousal. It also has a rapid onset of action with effects seen within a few days. So another positive thing there versus the 12 to 14 weeks that we're used to hearing with some currently available treatments. It's currently in phase 1 trials. They haven't submitted for approval just yet, but hey, in the next 1 or 2 years, we expect this one to be available. Next, we have NRX-101. It's a fixed dose combination of D-cycloserine and lurasidone by NRX. It's being studied for suicidal bipolar depression. NRX-101 contains lurasidone, which is currently on the market as Latuda, combined with D-cycloserine. It's thought that lurasidone and other 5-HT2A antagonists have a synergistic effect with D-cycloserine, so potentially enhancing the antidepressant effect, but minimizing side effects at the same time. Studies so far have demonstrated a statistically significant reduction in depression and suicidality compared to lurasidone alone. And then we have psilocybin, and that's right, magic mushrooms. You know, I couldn't finish without mentioning shrooms in Colorado. I think we're one of 2 states that have decriminalized it so far. It's currently being studied for the use in major depressive disorder. As with other products, the exact mechanism of action isn't known, but it's thought to be through modulation of the serotonergic system, primarily through 5-HT2A receptors. Thus far, studies have been small, and as you can imagine, it hasn't been an easy one to study, but still the findings are promising. Patients are experiencing symptom reduction within 1 to 2 treatments or 1 to 2 weeks. The studies that I've seen have been like a treatment once weekly. So certainly more is needed there to determine more safety, widespread and long-term efficacy, but another interesting option that's available.
Awesome. So I was waiting for the mushroom slide. I was so excited about that slide. Because like you said, we are in Colorado. So, and they actually do have conferences that discuss this. I know they had one recently here, and they have like a psychedelic theme to it. But they have, you know, legitimate speakers and go over these studies. And so maybe we should go sometime, Kim. I think it's good homework for us.
I have my son help me make a tie-dye shirt. He learned that
be so
last year.
So yeah, talking about how all of these treatment options are coming together, I wanted to give some real life consumer stories from, since I'm in the field, if you will, I wanted to give that real life stories and situations. And I think a benefit of working at Genoa is getting to see these breakthrough treatments, such as Spravato, and the impact that they have on someone's daily life. It's been very rewarding for me in my career to be able to do that. And I will say that Spravato is the first treatment for TRD that I've seen firsthand have these life-changing breakthroughs. So, you know, not to be cheesy or anything, but this is, you know, real life experience, which has been astounding. So we have a few clinics, as I mentioned, that we fill Spravato for, and we've got some patient stories from them. The first one said that there's been a patient that they've been seeing since 2021, and every time she came to the clinic, she would be in tears. She struggled with driving, with daily living, and just overall coping, and nothing had been working for her. She finally agreed to try Spravato. And when she came in just her second week, so we're talking days, not the months that we were mentioning earlier, she had done a 180. She was smiling and laughing and engaging. And the best thing was that she was not in tears for the first time. And she herself was in awe of the amount of change in such a small period of time. And she's now running for exercise. She can drive herself places. She's been able to manage her crisis thinking like never before. So her progress is amazing and an inspiration to keep doing what we do. Some other stories, several clients with similar stories with Spravato, where about a month into the treatment, they started noticing new things about themselves. So being on Spravato just cleared their mind to where they could do or see things about themselves that they otherwise hadn't before. One client stated that she used to just take her dog to the park for a walk and then go straight home. So it was a task on her to-do list. She checked it off and then she would just go straight home. Whereas now she finds that she can be outside, be in the park and enjoy it. She finds peace being outside with her dog instead of it being that check-off task. Another client that suffered from severe childhood trauma had been able to come to terms with the trauma on Spravato as the treatment again allowed her to focus her mind and be able to have deep self-thought and exploration to work through it with her therapist. There's so many more stories like this, but a final client we'll talk about was a client that's on the spectrum who had difficulty due to being quick to react from frustration, is now able to think things through more clearly and does not have the quick reactions that had previously affected relationships and friendships. So with all of these success stories, they have that same commonality where they found the right treatment that was the tool to help them to push themselves outside. It wasn't a magic thing. It was the right tool at the right time that allowed them to be able to work on themselves outside of the clinic. So being able to see this is just awesome.
Thank you so much for sharing. I have like chills, like how, I mean, incredible to come from somebody who was crying every time they came in to not, and, you know, maybe even smiling. It's just really awesome to hear that.
Yeah, it's like I said, it's just so rewarding and just makes you feel very like you're part of something great.
Mm-hmm. Glad to be a part of providing those options to those that need it. Let's take some questions from the chat.
All right, so we did have the chat disabled. So all the Q&A, if you guys still have questions, I think you can still put them in there, but I'll just open it up right now. See, so the first one from Craig Hodges is, have you had any luck getting L-methylfolate covered by insurance plans? So actually, yes and no. I will say, I don't know, Kim, if you have more experience in this too, but we have been able to get it covered through Colorado Medicaid. It typically does require a prior authorization, but we have been able to get it to go through. We do have clients that I believe have done the genetic testing to determine they have the genetic deficiency that might be on a commercial plan, and they get it covered that way. The copays still can be not ideal, but they're not super excessive. It's not hundreds of dollars. I think there's an L-methyl forte, which is a capsule, and that typically is more expensive. So we stick to the tablets, and that's been relatively inexpensive. We also use the Optum Perks discount card for those that, if it for some reason doesn't go through their insurance. And I know it's probably around under $20 is what I've seen. So it's not super excessively expensive. Have you seen that issue, Kim?
I would say my experience was similar, the yes or no. And that's good to know about the Optum Perks card, that like all of our pharmacies have access to that. I didn't realize that brought it to less than $20. So that's really awesome, because it's not quite the same, the L-methylfolate, as just taking folic acid, which is cheap and easy to get. And so if it's less than $20, then that's certainly more affordable.
It's, not ideal, but it is an option.
Yeah, cool.
The next question from Kristen Cox. Do you know if Medicaid or Medicare would cover genetic testing? That's a really good question. I actually don't know. When I was offered it at my primary care clinic, I was on a commercial plan, and they would have covered it it would have needed a prior authorization. So I remember them doing all of that, but with the diagnosis of postpartum, they did it. I'm not sure in Medicaid and Medicare. So that's a good question. I'm not sure if you know, Kim.
Yeah, I think that's kind of a similar thing, very plan specific. Some plans are a little bit more progressive and will allow, some may have the authorization required. And then I know that our partner clinic that I worked at, they had the ability to offer it like for free through some programs with the companies that offered the testing. So that's certainly something that we can provide more information on.
Yeah, definitely.
Via email. Yeah.
Awesome. Another question from Heather. Is Spravato FDA approved for TRD and approved by Medicaid? I'll let you take that, Kim.
Oh, well, yes, it is approved for treatment-resistant depression. I think that's kind of where that term really originated, was when that came about, Spravato. But so it is approved. And when you say approved by Medicaid, again, it's probably going to vary based upon different states, whether they cover it or not, or have step therapy requirements or prior authorizations that are needed. But if you want to let us know the state that you're in Heather, then, or actually, I think we probably have the information on the back end. We could probably get some more specific information for you as well. But what I would encourage is just reaching out with your Genoa partner pharmacy and exploring and asking them those questions, because they would be more intimately familiar with that state's Medicaid. Because as you know, 50 states, we have actually more than 50 Medicaid plans. And so they're all different, but your partner Genoa Pharmacy should be able to help or reach out to us if they need more help.
Yeah, and speaking on Colorado Medicaid, actually, I think the majority, if not all of the Spravatos that we fill are commercial plans. So I'm actually, I would think it would need a prior authorization, but I'm actually not 100% sure on that with Colorado either. So definitely I'll get back to you on that. But I know for sure it would probably need a prior auth. The next question from Dallas. Have you seen physician-patient barriers with prescribing Spravato given its relationship to ketamine? I have not. I actually have had so much interest in this from different clinics, from my own clinic. They're all very on board with it. They don't do, the clinics that I do fill for don't do the ketamine. Actually, I think one does the ketamine infusions, but typically they're just interested in this Spravato.
Yeah, I would say that as with any new therapy, and then Spravato is new, and it also is a little bit different. And then the misconception, well, not misconceptions, but what we hear about ketamine, it's different. And ketamine was not developed and necessarily catered to depression, whereas Spravato was created with depression in mind. But I would say that there certainly are some barriers with someone accepting a new treatment and then kind of really understanding how it is different. And it isn't the ketamine that you hear of on the news. It's the active isomer. It's a nasal spray. It's administered in a controlled environment. And so sometimes providing that education starts to help people to accept these new options. And plus, like, hearing about like that patient that had been crying every time, and then to see that they weren't, sometimes that's convincing enough to get somebody to take that leap into something new.
Definitely.
Yeah.
Awesome. Next question. I think this must have been an answer to that poll where it was other.
Yep.
It was cost, Medicaid coverage, and staffing shortage for the 2 hours monitoring. Yeah, I think that's and we'll get back to in the Medicaid coverage, like Kim said, but the staffing shortages for the 2 hours monitoring definitely has been a challenge for certain clinics, definitely. Oops, sorry, I had a pop up. Okay. The next question from Paula, the dosing of Stimbiax is difficult to make in separate medications. So we did discuss how it is in a fixed dose combination and you can separate it, but it is true, you can't get the exact dosing, but that has been the best workaround when the cost has been so high. Mm-hmm. Another one from an anonymous attendee. I like this question because it was what I thought at first too. In theory, and Kim, I'll let you take this question. In theory, it seems like you could dose out Delsym liquid OTC as long as dextromethorphan, as long-acting dextromethorphan. No, yeah. So talking about the Auvelity.
Which, yeah, I mean, and that's true. I think that you could. It's just that you would really have to look out to like the cost, your return on investment, so to speak, on that. The olanzapine and fluoxetine are very, very less expensive options and have been generic for a long time. Whereas Delsym, excuse me, or even the store brand cough syrup, long acting, their cost might be a concern there. So, excuse me, theoretically, but that is certainly possible.
Yeah. So then next question from Nicole, are there any supplemental options for L-methylfolate not requiring a prescription? That's a good question. I actually don't know the answer to that. I might have to get back to you on that. Do you know, Kim?
Yeah, we'll get back to you because I do think that we have a couple resources available. So when this gets posted on the blog, there will be some resources, and so we can certainly incorporate that in there.
And then Nicole also says that in Arizona, Medicaid does cover genetic testing. So that's awesome. Thank you for that.
Yeah.
And then Heather says she's in North Carolina and she'll ask her local Genoa to follow up on her questions. And then the last thing I think Actually, there's a couple more. Lastly, Nicole says Arizona Spravato, a prior auth requires 2 SSRI or SNRI fails. So thank you for that. And then the last question from Anonymous says, are there any legitimate concerns about using potentially habit-forming medications?
I mean, in our field, that is, I mean, that's Spravato is a controlled substance. I realize I didn't mention that specifically, right? But it's a controlled substance for a reason, right? But if things are used appropriately, and that's why they have like these REMS programs, and it is a controlled substance, then that should help to reduce those concerns. Because are there legitimate concerns? Certainly. There are concerns, but that's why there are multiple programs put into place to ensure safe and appropriate use of therapy. That way, those concerns aren't significant barriers into the actual benefit of those treatments.
And I think just from my experience, the clinics are very good about following the titration with Spravato. So, you know, where it's twice a week, and then it's weekly, and then it's every 2 weeks, and then it goes to monthly. And so they've been very good about following that. So it's not like they're allowing people to use and abuse it and continue on the twice a week for, you know, for a long time. They typically stick to the titration schedule. I think that's it.
And there's one more I just saw come in from Heather, an anecdote that she had a friend that accidentally experienced the drug interaction between mixed dextromethorphan and bupropion when she had a cold and started noticing hand tremors. So it's interesting because sometimes those interactions can be beneficial and sometimes not. So thanks for sharing that, Heather.
Thank you.
Yeah.
That's my intern, actually.
Oh.
So proud.
Cool.
Awesome.
Well, I think that's all that I see in there for now. And as I said, we'll incorporate some resources in the blog post. That way there are things available. And just a reminder too, that your clinic partner, the Genoa partner pharmacies are available and great resources. If they don't have the answer, they have the ability to contact us as well to help support, and whatever it takes to get these treatments to patients. That's what we want to help support those endeavors. So thank you all for your time and attention today and joining us. And again, if you have any questions, reach out to your clinic partners. I hope everyone has a great afternoon.
Thank you.
Mm-hmm.